Thank you for this very, very kind introduction. And I have been introduced, so I don't need to introduce myself. I'm glad and I'm also proud that I can be here to give you some background on facial infiltrating lipomatosis. I'm also honored. Thank you very much. Okay, let's give it a start. About facial infiltrating lipomatosis. And let's start with the clinical characteristics. And of course we need to talk about that, but I think most of the people who are here, they know them. We know that's a rare, non-hereditary disorder, so it's not passed from the parent to the baby. That's characterized by hemifacial overgrowth with fatty infiltration in soft tissues. And the clinical characteristics are that there's bony or soft tissue hypertrophy, there's overgrowth, there's hemimicroglossia, so an enlarged tongue on the one side. There may be premature dental eruption, macrodontia, so enlarged teeth, and there may be swellings, growth in the mouth that are called mucosal neuromas. I'll have a specific slide about that. And we know it's a rare condition, so there are less than 100 cases in the medical literature, and sometimes it may be isolated. There may be only a thick cheek, but sometimes it may be combined with other symptoms, and I'll come to that later in this presentation. And I want to start with a long patient journey, because Wilma already taught something about her journey, but I think you all recognize this. And this is a picture that I, of course, took from the internet. And here you see how a journey can be. There are first symptoms, maybe they are there at birth, maybe they come a little bit later. And of course you visit the primary care doctor and he doesn't know, but he tries to reassure, says, okay, it will go away. And that's something I hear daily in my clinical practice. And then you go online for answers, but this is in the present day. 25, 30 years ago, there was no internet yet, so there was no online, so you had to go to the pediatrician, and he or she didn't know it either, and okay, and then there's no diagnosis, or probably a wrong diagnosis, and there are treatments, because when there's a swelling, there's always someone who says, okay, let's cut it away, it will be gone. But as we know for FIL, we know there's sometimes there may be regrowth, so there are more specialist visits, more tests. And nowadays there is an option of genetic testing, and then you hopefully may go to the correct diagnosis. But this is how I think in most cases a recognizable long patient journey could look like, with the note that the online is something that has been a real good thing in the world of the rare diseases, and that wasn't there 25 years ago, so you were on your own. A long journey for the patient, but also a long journey for the condition itself, because it was first described in 1983. And in an article from Slavin and colleagues, and they said congenital infiltrating lipomatosis of the face is a distinct condition. It is something specific. And what we see that there are mature lipocytes, this fat cells, infiltrating in the surrounding tissue with recurrence after surgery. And at that time point it was interpreted as a hamartoma, and hamartoma is, I think, like a container begrip of a benign, slow-growing or self-limiting tumor. It's not malignant, it's benign. And it's unclear, at that time point it was unclear why it remained progressive, despite the fact that it were mature, so benign fat cells. Okay. These are the pictures of this first article from 1983, and they stated like 5 morphological hallmarks, and now we get like in a repeat, because again, infiltration of the fat into the surrounding tissue and bony hypertrophy, absence of malignant features, absence of lipoblasts. Lipoblasts are immature fat cells that could be malignant, but that's not the case. there's presence of fibrous elements, and there's increased blood vessels exhibiting with thickened walls, and there are increased nerve bundles as well associated with fibrosis, with fibrotic tissue. And in this article, they also said there's variants ranging from mild to more severe. Little sidestep to this mucosal neuromas. They are growth in the mouth, usually at the affected site. And what you see when you would look at them under the microscope, they consist of perineural hyperplasia. So they are kind of enlarged nerves where the mucosal tissue grows, gives growth in the mouth. And what with respect to the teeth, because that's also something very specific, what struck me that in the beginning they said you have a thick cheek, but the teeth, it doesn't have to do with it. So the connection was not made, but we know that it really has to do with it, of course. The early eruption of the baby teeth and the permanent teeth is specific. The teeth are larger, and the roots of the teeth, they are underdeveloped, so they are less good quality, giving that the teeth may go out earlier, or there may be more decay of the teeth. And in this study, it's from 2013, they studied 21 cases, and in 17 there was accelerated teeth formation and eruption. In 9 patients there were large teeth, and in 8 patients there was the hypoplasia of the roots, so less good quality of the roots. And this is a study from 2019, but of course there were earlier studies on histology, on looking at the cells under the microscope. And that's what we do when we don't understand it. Let's look how it looks under the microscope. And then, as we can understand, there is adipose tissue, fat cells diffusely infiltrated into the submucosa, so in the mucosa, in the skin, in the muscles, in the parotid glands, or in the salivary glands. And again, with the absence of the lipoblasts, so the mature fat cells, not unripe fat cells, or without malignant characteristics. And when we look at the cause as considered in the past, it was unknown, but there were several pathogenic mechanisms that have been proposed, such as probably in relation to a virus. There are some conditions that are related to, but nowadays we know that's not the fact. Or probably with something with abnormal angiogenesis, vessels that grow, or something genetic. And that's really what we are heading to, of course. Somatic mutation in adipose stem cells, probably. Those are all thoughts about what could be the cause of facial infiltrating dermatosis. And then I want to go a little bit back about what we've learned in the recent years about genetic knowledge in vascular overgrowth syndromes, or syndromes with a vascular component. And in 2007, it was the first time that the Cloves syndrome was described. I don't know, maybe you have ever heard of it. I'll show some pictures later. And Cloves syndrome is a condition that is more or less all over the body, with congenital lipomas overgrowth, sometimes on your thorax or on your back, with vascular anomalies, with skin anomalies, or with skeletal anomalies. And also that's sporadically occurring and non-hereditary, so you don't pass it to your kid, or you don't get it from your parents. And in this condition also, and there's only one word in this first article, an asymmetric face was described. Okay. Here are some clinical features of Cloves syndrome, and you see that there may be a big a toe, a big toe. There may be swellings on your back, and also in this article you see swelling of the cheek. And then we go on, because in 2012, Clove syndrome, the genetic cause was found, and Clove syndrome was caused by a post-zygotic activating mutation in PIK3ca. That's, I'll have an, I hope that's the next slide. Yeah, with respect to activating somatic mutations, I'll show you this one, and maybe you have seen this already, but in many conditions, the left picture is leading, and that is when there are germline mutations, when there's a condition that goes from the parent to the child, and there are many conditions like that. And then there's, as you see, the gamete, so the sex cells, they are already affected, and you see that the whole embryo is affected and the whole child that gets born is affected. And when this person, in this case, when this man becomes a father, he gives this condition to a child. And this is not the case, or in vascular syndromes, this is not the case in Cloves and not in FIL. In FIL and in Cloves, you have the middle picture. And what we see is that the sex cells are normal, and in the embryonal phase, there are still many normal, but there's one mutation that can survive. So there is a baby born, and in this case you see that I think the somatic mutation was there at the moment that this arm was formed, and you see that in this case condition, port wine stain, whatever, is only in the arm and not in the reproductive organs. So when this person becomes a father, or when it was a woman, when she becomes a woman, there are normal sex cells, so that the condition is not given to the offspring. So many of the conditions, like Cloves and also like FIL, they have this kind of pattern, and this is a somatic mutation, and that's usually an activating mutation. So we know that the cells that have this other DNA, they seem to work a little bit harder. The growth is a little bit faster. The vessels are a little bit wider. So that's what we call a somatic mutation. And this is like more of a complex, and I just took it just to see, to illustrate that here at week 7 to 8, at day 49 to 56, we think that the mutation, like in PIK3ca, could occur, and then we know, depending on the timing and depending on the localization of the mutation, there may be different clinical pictures. When it's at the arm, you can have a bigger hand. When it's in the head, you may have a bigger head. And sometimes it's more extensive, as you see, that there are more affected locations. And then we come back to PIK3ca, to facial infiltrating lipomatosis, because in the beginning, this Clove syndrome, and this is like a typical patients with Clove syndrome, with big feet, as you see, with a scoliosis, but also with a thick cheek. And in this article, and they were of course good observers, they said the phenotypic features of FIL are sometimes seen in patients with Clove syndrome. And in this study, they analyzed the DNA of the affected FIL patients, and it was found that the affected tissue of patients with FIL contains these PIK3ca mutations. Now, it's not new, but it was new at that time point. So FIL is part of the PIK3ca overgrowth spectrum. And this is a slide that must also be familiar, because PIK3ca can cause many different clinical features, and this is of course knowledge of about 10 years now, but here you see the FIL and the Cloves, but there are many other symptoms like Klippel-Tredonet syndrome. That's also one of the patient groups that I see a lot, but also epidermal nevi. And in the past, we used to try to say there are all different things. Cloves is something else, and Klippel-Tredonet is something else, and FIL, we really didn't know it yet. But in the past, we tried to say that there are different conditions, and now we understand that there is much overlap, and we understand better how the conditions go. I want to give some extra pictures about this PIK3ca related overgrowth spectrum, and that's what we call PROS. So it's like you could call it almost a new condition, where you see that people can have overgrowth of the thorax, of the cheek, of the toes, and you can understand that depending on the time and location of this early somatic mutation, it can have all different kinds of clinical features. This is a recent article where they say try to group the PIK3ca-related disorders into the overgrowth spectrum. That's on the left. In the middle there are the vascular anomalies. And on the right, and for me as a dermatologist, it's quite interesting that there are also the epidermal nevi, the specific bigger nevi. They also may have a PIK3ca cause. And then with respect to the rarity, how rare is it? In my practice of vascular malformation patients, I see facial asymmetry more often in people who are seriously affected, like this patient from an article. It's not, of course, not a patient of mine. And sometimes it's mild, and sometimes it's more pronounced. And when I look at my patients, they are in the group that we used to call cloves or proteus even. But in this group, the facial infiltrating lipomatosis symptoms is often not the only problem, and also not the main problem. And sometimes I see a patient and he has problems with his leg, but there's also some slight asymmetry of his face. And from that point, I would say that the picture of FIL may be less rare than suspected in literature, but future will tell us. Okay, the long patient journey. I'm wrapping it up. Knowing what you have, and Wilma is of course a very good example of that, gives you a new perspective. Makes us understand the cause of the disease. Now we understand why it's progressive after surgery. And also makes us less lonely. And having the exact genetic diagnosis eventually leads to targeted therapy. And speakers later this day will give illustration. I won't talk about that. So this gives us a new horizon. This is my last slide. Today, as we all feel, is a unique event. Many people with FIL together. And that was, of course, an idea of Wilma, is a unique opportunity to learn even more about FIL, about the presentation, about the cause, about the journey to the diagnosis, about treatment outcomes, and about quality of life. And we had the idea of a questionnaire research. Therefore, my question to you, together with Wilma, of course, could we contact you for further research via mail? And I have some informed consents here, so if you want to participate, you can give us your contact numbers and you can consent. And with the finals, are there probably research questions that you would like to see answered in such a survey? So please help us together. Thank you very much.
If anyone wants to participate in the study, I would suggest fill in the forms during the break. Does anyone have any questions for Dr. van der Vleuten? Was everything clear? I mean, you're here. Questions, you must have any questions. So then I'll start it off, and then meanwhile you can think of one. How many FIL patients do you roughly have in Nijmegen? Or feel like? Maybe.
Yeah, no, that's a good question. Usually I don't see him weekly, so I think in the total I have about 3, 4, well, I think about 5. But as I recognize the clinical picture more clearly, I think I must have 5, 6, 7 or more that have also that are more severely attached on other parts of the body, and for them the facial overgrowth is not the primary problem. Mm-hmm. And for instance, I had one patient who was attached more on the rest of his body, and he did very well with the right ortho, the beugels, with the braces, and with he had not to be operated upon, so he got a little bit better. But because they are less severely affected. But I think I've about 5 solitary FIL patients and about 10 who have this kind of. But I see, of course, many patients with vascular overgrowth syndromes. Yeah.
And you talked a lot about the long journey for the patient, but at some point it must also have been a long journey for you. Yeah. Because at some point you had observed the first one. Yeah. So do you still remember that moment, and how long did it took you to get to a
of course I cannot speak about individual patients, but I'm of course Wilma was my first patient, and I remember, I hope I'm not saying too much, but I remember that I thought, okay, what is going on there in this cheek? And when I have such a question, I always want to do an echo. You're okay with it? Yeah, okay. I want to do an echo.
I will intervene a bit.
But it's okay. I want to do an echo. So I saw this letter of referral. I said, okay, let's combine the echo with the first consultation. And Wilma contacted us and said, I don't want an echo. I want an MRI. And I said, okay, but I want an echo, and I'm the doctor. and so we did this echo, and when the echo they did not see any vascular, and that's of course my point of interest are the vascular anomalies. So I said, it's only fat. How can it be? And then I started studying in literature, and then I came of course across, and I saw of course the clinical pictures that you saw later, and I said, this must be what she has, and so that's my journey. And maybe an MRI would also have made the distinction between fat and vessels, but in this echo it was clear. And later I got more patients, and then our echographists, they say it's like an infiltrating lipomatosis, and they can see that because usually it's encapsulated. It's like a lipoma. When you see an MRI or see an echo, it's like it starts somewhere and ends somewhere. But this is more diffuse, and that's what an echo can really could make a distinction.
I also still recall that moment.
Yes.
Especially when you called us and said, well, I think I know what she has. And I'm like, that's not possible. Because you found it very quick.
Yeah.
Any questions? John?
Yeah. It's growing. Does it stop growing? Or does it stop and start? I mean, say, when I was younger, my cheek was big. But now I feel like I'm older now, and the fat has got nowhere to go here, so it's going up.
Yeah.
I mean, say, a couple of years ago, I could put my glasses on easy, and I can't do that now. And I feel it and I see it, that this side of my face is getting bigger as well. And it's just, as I say, it's like, oh, I can't go that way anymore, so I'm going to go up. And I don't know, is that the way it works?
As it's such a rare disease, I do not have so much experience myself, but what we know from vascular anomalies, because that's I have more experience on that, we know that it's slowly, it may be slowly progressive. And we know, for instance, in women after the postmenopausal phase, there may also be some further progression, and also I think, but I do not really understand why it wasn't in your case, why it was here. Why it wasn't here earlier and why it's I really don't know, but it must have something to do with where those cells came during the embryonal phase.
Yeah, see, look, I've gone 60 years where you said, oh, you were born like that.
Yeah.
That's it.
Yeah.
I mean, nobody told me anything.
No.
You were born like that.
Yeah.
And the only clue I ever got with some women.
Yeah. Yeah.
She's the one who's given us a lot of
Yeah.
clues and a lot of
Yeah.
answers
Yeah.
through you, of course,
Yeah.
and your group.
Yeah.
But as far as the rest, I say I'm 70 years old.
Yeah.
When they were operating on me, it was 60 years ago.
Mm-hmm.
You know, I mean, say that's like with a hammer and
Yeah.
a chisel
Yeah. Yeah.
compared to what you can do now.
Yeah.
But
See that Dr. Wayne wants to comment.
Yeah, so I think the most important is what you've done, because as physicians, we'll see 1 or 2 or 3 or 5 patients, but we don't have the luxury of many, many patients. But as a group, Vilma and all of you can get together and give us a lot more information than we already have, because the literature is very not very full of experience. But as a collective group, if you all get together and compare notes, we'll learn a hell of a lot more than we already know. So the importance of the group should be underscored.
And also with respect to what happens when you get 50, 60, 70,
Yeah.
how's
Yeah.
progression? We don't know that yet.
well, at least we know we can grow old.
Yeah,
You know?
that's also important.
That's a
Yeah.
first part.
Yeah.
Well, thank you for that.
Yeah.
Stephanie.
So I was just going to bring on from the point that you said for women postmenopausal, there is possibility for it kind of kick in, I'm assuming, just for hormone changes and things like that.
In vascular anomalies, we know that. Yeah.
So, but what is the patient group size that you've experienced that in? I.e., could it happen to one of us? Or is it more of a rare occasion? Or is out of 10 patients it's happened in 7? Or?
Yeah, I'm not. I cannot give you figures, but from my own experience, especially in the vascular anomalies, I already saw that then when there was like a port wine stain, or there was some extra veins, vessels. I saw that when people got older, there came little growths or it expanded a little. And in the beginning, I thought, oh, it has just to do with the fact that the tissue is getting a little bit loose. So there's a little bit, just the pressure is easier on these vessels. But that was not only the point. So I started reading about the literature, and it has been described that as I told you, in women after the menopause, there is some progression, and they thought it were like indeed the hormonal changes. And when I look at it now, many patients that are a little bit older, about 50 or about 60, they usually don't visit us that much anymore because they learn to live with it, so when I see those patients, they tell me that it is a little bit progressive, and I cannot say whether I've noticed it with 10 patients. I think I've noticed it more than that it's a little bit progressive. Yeah.
Have you ever done echo-color Doppler, how to say the English, of the veins and the artery of the neck?
Yeah, I understand, but no.
3 years ago, I made one of the neck, right and the left side, and we saw that my left side, the artery of the vein, was blocked.
Okay.
Yeah, and
Okay.
we use bite to open the jaw and change the position of the jaw, and we saw that the vein opened, and the regular flow of the blood was getting better.
Yeah.
And so after 9 months of using a bite during the day, my
Sorry,
cheek,
what do you use? Yeah, okay, yeah.
yeah, I don't know what to say.
Yeah, I understand. So there's something.
was,
Yeah.
something that we put on the teeth.
Yeah.
And after 9 months, my cheek was diminished,
Okay.
and also the vascular circulation of the cheek was very better, and my left vein was open.
Oh, yeah.
And so this was better before and after.
Yeah.
So
Okay.
we changed all the teeth after that, get approved that was going well. So we changed completely the teeth and also reduce the pain of the articular level.
Okay. Okay. Now that we were asking for new research questions, that might be one. What about the vasculature?
So I was wondering if
no experience with that. No.
Anyone else? Any questions?
Yeah, questions.
Sure.
Maybe it's also for Wilma. Sometimes I'm wondering what we can do to better cooperation. Because
I think maybe the first small step we can do is if you're interested in joining the study and if you have ideas what we can study, please fill out the form. Let us know. So for example, what you just told about the vascular part, please fill out the form because then we can include it in the, maybe you have other topics, like for example, I'm very curious about how many of the FIL patients also have the brain affected and how many of them have, for example, epilepsy or developmental delay, because we have quite some of them in the group. But also like left side, right side, twins, because I've noticed that we have quite some twins in the group. Like, is this something or is it just random? I don't know. So all these things, anything you can think of, please write it down and we will try to.
Yeah.